Good morning, good afternoon, good evening. Welcome back, everyone. In session 2, we're focusing on prevention, treatment, and cures. We have 4 distinguished medical professionals to help us to answer all the questions that we have, and around 17,000 people, as you know, register. Again, if you have questions for the panel, please make sure you submit your questions using the option on the screen. Our experts in this group include a very distinguished, as I say, group of individuals. First of all, let me introduce them, and it's an honor for me to share this opportunity with all of them. First, Dr. Joel Molen, Associate Dean for Health Equity in the Dell Medical School at the University of Texas at Austin, and the former Principal of Deputy Assistant Secretary for Health in the U.S. Department of Health and Human Services. He was also a key contributor on the state and federal responses for Zika and Ebola. Very impressive. We also have with us Dr. Adolfo Garcia Sastre, the Director of the Global Health and Emerging Pathogens Institute and Professor of Microbiology and Medicine, Infectious Disease of the Icahn School of Medicine at Mount Sinai in New York City. Welcome also, Dr. Garcia Sastre. Dr. Vivek Murthy, former Vice Admiral of the Public Health Service Commission Corps and served as the 19th Surgeon General of the United States. He's author of Together, a book of the crisis of loneliness in today's world. Welcome, Dr. Murthy. And finally, Dr. Julio Frank, who's the president of the University of Miami, professor of public health sciences at the Leonard Miller School of Medicine. And he is also the former Secretary of Health in Mexico. And let me tell you, prior to joining the University of Miami, he was the dean for almost 7 years for Harvard THN School of Public Health. Welcome, Julio. Welcome, everyone. We are so grateful to have you here today and taking the time with us. I'd like to ask Arnold to start this session. Thank you for joining us.
Hey, thank you, Gloria, and welcome to the panelists. We want to start this session with the science behind prevention. So Dr. Mullen, first of all, I want to thank you again for being here, but we're all familiar with the most common and simple prevention tools, physical distancing and masks, but there's still a lot of confusion around it all and a lot of non-compliance. The question is, what is the science behind the prevention? What's the most effective prevention measures, and how risky are social gatherings if all precautions are fully adopted? So Dr. Mullen.
Thank you. It's really nice to be here. And I want to start as the public health doctor by saying that it's so important not to underestimate how important those simple things really are. Masks, for example. I spend a lot of time encouraging people not to get hung up in the little bit of differences that people might have in the way in which they recommend masks, and instead remember that all of us public health experts agree that they offer some protection, especially along with other preventive measures. I'm not talking about doctors here, so I'm talking about simple cloth face coverings, bandanas, masks that people can make on their own, a few layers of cotton made from bandanas, t-shirts, bed sheets really help. And the way in which we believe they help is that they keep down our risk of spreading coronavirus to others, which is really important because people can have the infection and not even know it.
Okay. And so, Doctor, what are some of the better masks? Which ones, if you were going to recommend, what would you recommend and why? What factor does social distancing play? Do you need to do both? And are you comfortable in social gatherings, and in which circumstances are you comfortable in social gatherings? Go ahead.
Yes. So I wear masks when I go out, and even if I'm going out to exercise, I take one with me, knowing that if I'm out in an open space, I might end up close to someone. So what's best? Well, as a doctor, if I were working in the hospital in a healthcare setting, I would use those N95 respirators or surgical masks, but the general public does not need to use those. And that's where cloth masks that many people see and use are fine. Not nylon, not things you can just see through that are very airy. That's one. And once again, what we believe mostly is that they cut down on the risk of spreading to others. Now, keeping distance is so important because we know that this is a respiratory infection that spreads through talking, through coughing, through sneezing. And the best estimates are that when we breathe out, the particles that come when we breathe out hang in the air maybe up to 6 feet, which is why you hear recommendations of physical distancing between a little over a yard or a meter to almost 2 yards. Once again, as a doctor, public health doctor, I say these are the abundance of precaution measures that are based on the best science that we know right now. And crowding is important to think about because we can't control everything around us. We don't know who we're close to. And the more people crowded into a small place, the more people are also touching surfaces and potentially spreading infection in ways that it will make it easier for us to pick it up.
Thank you, doctor. Let me ask you. Yes, I do have a question. Let me ask you a question because you talk about the amount of people and crowded and all of that. Would it be fair? Are you comfortable going to a celebration, a birthday celebration, or are you comfortable going to the theaters, or are you comfortable? What situations you are not comfortable based in where we are, or wearing a mask and maintaining some sort of minimum social distance or physical distance actually would help and you will be okay? Can you comment on that, please?
Yes. And part of that comfort is going to depend on how much COVID is spreading in a community. The bigger the gathering in general, the more chance of people being crowded together and being exposed to even more people to up the odds that you might come in contact with someone who has the infection, which is why I'm comfortable and glad right now not to see mass gatherings, not to see big concerts, big sporting events, big racing events, big parties. Personally, living in 2 places, one with very low transmission right now and one with very high transmission, my biggest comfort is staying home. It really is. Going to the supermarket when it's not crowded. If I get together with any friends or family, we oftentimes still stay outside where we can spread out more. And these kinds of decisions about how close or how close up to be or how many people can gather really depend on how much spread there is in a community. But with the widespread transmission we're seeing in most parts of the US right now, I would say small gatherings, no more than 6 people, no more than 10 people, and certainly not big parties and not big social events. I believe that it's been extremely wise that restaurants and bars in places that are what I would call very hot be closed down again. And I believe that along the way, the more that we have to turn things back a little bit, the more people are learning that these things really matter, because what we see is when we back off, the cases go down again. And when there's not absolute science, it's that kinds of experience that helps us know that we're doing the right things.
Now, before we move on, I have one practical question that has come across, and it's so popular, I have to ask it. So the question is about face shields. And people are saying, if I have a face shield, do I need to wear a mask? And then related to that is the concept of, what transmits more, through the mouth or through the nose when it's breathing. So if you can answer those 2 questions and give people advice, I think they'd appreciate it.
So my understanding is that face shields are especially helpful to prevent against the spraying and right. But in terms of those, what I call the particles that some people refer to as droplets that people breathe in, a face covering is still going to make a difference there. I believe that's really the case.
Okay, thank you.
Okay, you're welcome.
All right, Gloria, you want to move on to the next?
Thank you. Yes, thank you, Dr. Mullen. We appreciate it. And as we continue with the questions, I would like now to take the opportunity to ask Dr. Garcia Sastre. Thank you for joining us today and taking the time of your busy schedule. I would like to ask you, how does COVID-19 compare to influenza as far as the impact on global health? Could you comment on that? And at the same time, what are the current and proven therapies, if there are any, for COVID-19 today? Could you please share that with us?
Yes, and let me thank you. Thank you for having me here. I'm happy to try to answer the questions that we know and tell you also what we don't know, because there are things that we don't know. So in terms of comparison between COVID-19 and influenza, there are several similarities. Transmission is very similar. It's a respiratory virus that transmits through droplets. The type of prevention measures that one can try to do in order to prevent transmission, they are very similar. Now, why we are not doing the same thing with influenza every year, but we are doing this thing with COVID-19? The main difference is two. Two are the major differences between COVID-19 and influenza. The first one is that for COVID-19, everybody is susceptible to be infected. Nobody has any type of immunity against this new virus, and because of that, the number of cases that can happen if the virus transmit the way it transmits without any type of prevention is going to be extremely high, and this is going to result in a lot of disease, even though the majority of the people don't have disease. But a lot of cases, let's say 5% get disease, they need to go to the hospital. 5% doesn't seem like a big number, but still, it's a lot of people, and 5% of a lot of people is a lot of people. And the second thing that is different between influenza and COVID-19 is that we don't have the tools that we need to have in terms of antivirals and vaccines that we have for influenza. For influenza, it will have been much quickly to get a vaccine because we know how the vaccines have been made for influenza. Even if it's a pandemic influenza, which could be the closest that there is to COVID-19, a completely new influenza virus for which we don't have pre-existing immunity, that could cause as much problems as COVID-19, like what happened, for example, in 1918. Even if it will be a pandemic influenza like that, we know how to make a vaccine against influenza, and then the vaccine will be made faster. Plus, we have antivirals against influenza. We have several compounds that can be used for the treatment of influenza, and that's what we don't have yet for COVID-19. So it's a virus. COVID-19 is a pandemic virus. Everybody is susceptible to that, and that's the reason why there is more concerns about COVID-19 than there is about influenza at this moment.
Arnon?
So, as we go through it, what therapies do exist today to mitigate the symptom development that was referred to in the first panel, and people know firsthand as they've seen people suffer. And so what are therapies that already exist that are helpful in the population? And then what are those you feel are nearest to coming to fruition that can mitigate the effects so society can live better with the virus?
Yeah. With respect to therapies, I think it's important to consider that one could think about two different types of therapies. First type of therapy is the one that tries to recover people that have already very severe symptoms. At the time that one gets severe symptoms, that one gets to the hospital, that is really in bad shape, the amount of virus that one has replicating in the body is not as much. Right now, the symptoms are caused by a response that has been going wrong against the virus, and there are multiple organs that are failing. That's why most of the treatments that they will be done for people that have severe disease that target inhibition of the virus are going to be hard to work. Because inhibiting the virus is not what you need at this moment. At this moment, what you need is to inhibit the severe symptoms that are caused by the response of the host. And most of the treatments have been now being geared, because of this is what is one of the things that is needed, towards trying to recover people with severe symptoms. For that, we have right now one of the things that seems to work, but not as good as we would like, is dexamethasone. It seems this is an immunosuppressor that is actually very cheap also, so it's very easy to use. But it rescues some people that have severe disease, but not everybody that has severe disease. So we still need to have better things for people that have severe disease, and perhaps even having treatments that are according to the actual disease that the person has, because there are multiple different diseases that happens in people according to their comorbidities. There are people that have more problems with coagulation. There are people that have more problems with respiratory symptoms. There are people that have a very high inflammatory response. There are people that have respiratory insufficient. So perhaps there we need a combination of different drugs that treat the symptoms, and they need to be more personalized than what we have right now. So there are drugs that have been trying to be used at this moment. But that's how we are right now. Now, the other type of treatments is treatments that block the viral replication. These type of treatments are going to be more effective very early on. When people just get infected, start to have the very first symptoms, mild symptoms, they have been diagnosed as having the virus, and then at this moment, if you have something that effectively knocks down viral replication, then that's going to prevent disease progression to more severe disease, or even if there will not be progression to more severe disease, like in a lot of cases, that will be stopping transmission, stopping to be contagious. These type of treatments, they are based on drugs that inhibit viral replication. There are several ones that seems to have effects, at least in vitro. Remdesivir is one of them, and remdesivir has shown also some effects. But I think remdesivir will be even better if one could treat people early on. And the problem with remdesivir, which I think is a very good inhibitor, the main problem is that it needs to be given intravenously. So for a person that has mild symptoms, it's very difficult to be treated with remdesivir. So we need some better drugs that can be taken perhaps orally or through an aerosol spray, that they will be more easy to administer, that will stop viral replication. And there are several candidates that could be promising on that. But the type of clinical trials, the type of studies that need to be done to prove effectiveness of these treatments are more complicated than the ones that are from people that are hospitalized, where you have the people in the hospital, you treat them, you see whether they get better. While for getting someone that has mild symptoms, you need to identify the people with mild symptoms, you need to sign them, you need to give it the drug, you need to follow them up. So it's a little bit more difficult to establish the clinical trials that are required to demonstrate effectiveness. And that's the problem, that there is getting very quickly a good antiviral, which I think that most likely we have among the things that have been trying something that will work well. Now, the final thing I want to comment is the convalescent sera, because that's something that has been also, we heard a lot about it, the use of antibodies, either antibodies or antibodies from people that have seen the virus. This is a very, it's likely that it's a treatment that will work, but again, it needs to be administered early on. The earliest, the better, because again, what is going to do this treatment is inhibiting viral replication, not so much inhibiting the very severe symptoms. So we can catch up the people when they start to have severe symptoms very early on. That will be the best way how we can make an impact with treatments like that, like antibodies or like plasma from convalescent sera from people.
And so hydroxychloroquine.
Yeah.
Would you classify that as a myth? Would you classify it as something that still needs additional science? Or would you classify it as something that is confirmed to help certain people in certain situations?
Yeah. So hydroxychloroquine is clearly an inhibitor of viral replication when it's being used in tissue culture, but it's not a very efficient one. It requires concentrations that are close to micromolar. And the majority of the studies that have been done, including studies that have been now published in animal models, so that there is no good effect in when you administer it in vivo, most likely because it does not reach the concentration that is needed for inhibit viral replication. And even if it will reach this concentration, it may start to have very adverse adverse events, because it's a drug that we don't know exactly how it works. And again, you need a very high, against COVID-19, and you need a very high concentration. more than, for example, remdesivir. So at this moment, I don't think we have any evidence whatsoever that hydroxychloroquine works in for patients, and therefore is one thing that I would not recommend.
Thank you. Okay. All right.
That is very helpful. Thank you, Dr. Garcia Sastre. Thank you very much. I think we would like to move on with the rest of the questions. Arnold, do you want to continue with Dr. Murthy and the other questions?
Absolutely. So, Dr. Murthy, first of all, it's a pleasure to have you with us here today. I'm really great to see you as a former Surgeon General of the United States. You're well-versed on managing public health issues on a national, even a global scale. And you've also been a strong advocate for vaccines. So, and is a vaccine going to be the ultimate solution for COVID-19? And can you just explain a little bit how it works and what some of the challenges would be?
Sure. Well, thank you, Arnold, and thank you, Gloria. It's good to be with all of you today. It's a very timely question because we just got news in the last 24 hours that two candidates for vaccines that we've been following closely have now started in late-stage human trials. And the good news about vaccines is that we have now 27 vaccine candidates that are in some form of human trials. And let's just back up for a moment and just recap what vaccines are. Well, vaccines are essentially a therapeutic, usually a shot that's administered in the arm, although not always, but something that we can give people that helps to prompts their body to develop immunity against a virus. And it usually does that by getting the body to develop antibodies, which are special proteins that can identify and attach to a virus and then signal to your immune system that foreign invader, that virus, should be destroyed. But vaccines can also activate other parts of the immune system. So they can also activate a certain type of cells called T cells, which can help in the immune response. And what you see in the vaccine candidates that are currently being talked about in the news is that what people are trying to understand are a few things. One is, what kind of immunity do these vaccines actually elicit in the body? Is that even if you find, for example, that antibodies are being produced against the coronavirus, once you give somebody a COVID-19 vaccine, the question is, are they sufficient in number and in quality to actually prevent the person from getting infected? Or maybe they don't prevent infection, but they reduce the severity or the intensity of the infection. So those are some of the questions that we are trying to figure out. What we're also trying to understand with vaccines are, of course, are issues related to safety. So if a vaccine is really good at generating immunity, but it generates also a lot of side effects in the process, then it's not as optimal. So the safety piece is what we're studying too. And of course, what all of us want to know is, even if these vaccines are effective, how long do they last? Do they just last a year, and will we need to get them every year like we get the flu vaccine? Or will they be more similar to the measles vaccine and actually last for many, many years? And these are circumstances where only time will really tell us. Like, we can't fully know the answer to how long immunity will last from the get-go. We have to do the right studies. And so what's happening now is a balance between trying to be as quick and as efficient as possible in beginning these human trials and seeing what the effects are, but also being careful enough and taking the right time to ensure that we're doing this safely and effectively. The last couple of things that I would just say before I pause on this is that, as important as it is to develop a vaccine, the real, also second half of that challenge is to figure out how to administer it. And that is no small task, because it turns out that if you look at the experience that the United States had with H1N1, which was a challenge that we struggled with back in 2009, 2010, it took about 5 months to vaccinate 80 million people with the vaccine. Now, that's actually a sobering number, because if we were to go on that pace, that same pace, when a COVID-19 vaccine became available, that would simply take too long to vaccinate the entire population. And how many people do we actually have to vaccinate? That's also an important question. Now, to get to herd immunity levels, we typically need to get somewhere in the range of around 70% of the population that's immune. The number of people, even though we've had so many people who have been infected with COVID in the United States and around the world, the overall community immunity, as we think about it, is likely still quite low. And so we're likely going to have to vaccinate a large number of people. Now, if the vaccine turns out to be, let's say, 100% effective, which would be extremely rare, but if it's 100% effective, then we would need to vaccinate maybe only at 70% of the population. But the truth is that most vaccines don't hit that number, right? So on the one extreme, you have the measles vaccine, which you give the 2 doses that are required, will actually get well above 95% effectiveness. But then you also, on the other hand, have the flu vaccine, which varies in its efficacy from year to year, but on average is around 40% effective. And so if you have a vaccine that's less effective, that increases the number of people that you have to vaccinate in the population to achieve any sort of herd immunity. And the other challenges that we should think about with distribution have to do with the following. It's if you have a vaccine that is a 2-dose vaccine instead of a 1-dose vaccine, then that significantly increases the logistical challenges. You also have to be mindful that when you're trying to do a massive vaccination campaign, that you start running out of basic materials and syringes and other things we may take for granted, but which need to be mass produced in advance. And public education ends up being another component of vaccine campaigns that's incredibly important. We know at baseline that there are a number of people in the population who are hesitant about receiving vaccines. And some of that may be personal beliefs, some of it may be based on information they've received, and there unfortunately are a lot of myths circulating about vaccines. But what we've seen with COVID-19 is that in the United States, at least, in a poll that was done about a month and a half ago, they actually found that about 50% of people polled said that they were either unlikely to take a vaccine or uncertain about taking a COVID-19 vaccine, even if it was available today. And you might ask, why is that number so high if the urgency around COVID is so great, and if it's shutting down our lives and everyone wants to get back to normal, and a vaccine is seen as one of the pathways that might help us get there? Well, this is where, again, misinformation campaigns become so important to be aware of and to counteract, because we're already seeing a lot of misinformation about the COVID-19 vaccine, even though we don't have one that is safe and approved yet. And with all the talk about rushing to develop a vaccine, sometimes people wonder, are we doing it in the safest way possible? And that's why it is so critical at this phase that we put forward scientists and public health experts to speak directly to the public around the world as much as possible, to give them the evidence as we're getting it about what we know about these vaccines. It's why it's important that teams of scientists analyze this data dispassionately, and that we don't just take a press release that's issued by a company as evidence that a vaccine is ready for prime time to be distributed. So these are some of the challenges that we have to think through. I actually remain optimistic that we will get a vaccine and hopefully a good vaccine. I'm optimistic about our chances of getting it to many people in the population, but it won't be easy, and it will take a dedicated plan for not just development, but also distribution of the vaccine.
So practically speaking, Dr. Murthy, there's about 165 candidates for vaccines. There's, you mentioned 27 that have made it to human trials, and there's about 6 that are either in phase 3 clinical trials or about to be in phase 3 clinical trials. But with all of that and what you just described as the challenges for distribution, adoption, et cetera, what's a reasonable projection for a time frame that we would have a vaccine through the population as a really determining tool for the mitigation of the spread of COVID-19?
Well, that's a great question, Arnold. And I think the good news is we got all of these candidates in trials, and there are several that are in late-stage human trials. So it's possible that within the next several months, we will get some preliminary data from them. But I think that even in an optimistic scenario, it would likely be closer to mid 2021 that we would see vaccines starting to be distributed at scale. And if we think about how long it would take for that vaccine to actually make it to everyone in the population, we would need to, the question is there a chance we could do this all and vaccinate 70% of the population by the end of 2021? I think it would take the best vaccination campaign that we've ever assembled in the history of the world to do that. Could it be done? Well, there's a first time for everything. But I think I mentioned this with some soberness because I think it's important for us to recognize that even if we had a candidate available tomorrow that we had good data on that was both safe and effective, we should not presume that the COVID-19 threat will be over in a few months, and that all of the measures that Dr. Mullen spoke about, that Dr. Garcia Sastre spoke about in terms of being able to keep our foot on the accelerator in developing therapeutics, that will all be incredibly important because there will still be virus floating around. We'll still need to wear masks, still need to distance. If we develop our testing capacity sufficiently and bolster our contact tracing ability, then it is possible that we would be able to start opening up schools and businesses and other parts of society while still taking all of these precautions. But if the goal is to return life to some semblance of what it was like pre-pandemic, I don't see that happening in 2021.
Thank you, Dr. Vivek. Gloria, did you have a question?
Well, I just have a quick question, Doctor, before we move to the next session. I'm based in London, and we hear a lot about the Oxford here vaccine. I just wanted to know, based on all the information, and you say what's in the news, what is the most promising in your mind from all the trials right now going on?
Well, that's a great question, Gloria. And certainly the news of the Oxford vaccine, which they are developing in partnership with AstraZeneca, that news has made its way all over the world, and it's I think a widely anticipated a late phase trial that we're all hoping to get good information from. But I would say, Gloria, at this point, it's very difficult to say which vaccine candidate is the most likely to succeed, because there are still a lot of open questions, even based on the early results we've seen about how these vaccines will perform in the real world and in populations at scale. So some of the questions that we have to answer is, number one, will the level of immunity that they induce in a larger population be sufficient to reduce either people getting the virus or the severity of the virus? The second question is, will these candidates actually create immunity that lasts for a long period of time? And we don't know that. The third question is, how will different segments of the population react to this virus? In many cases, many of the vaccine candidates we're hearing about have, to this day, been tested primarily in young and healthy populations. But we know that some of our greatest concern is for the elderly. And so open question still is, how will people who are older react to this vaccine? How will people who have other conditions that raise your risk of poor outcomes, like diabetes and heart failure, how will they react to this vaccine? Will it protect them? And that's some of the information we're hoping to find out in these phase 3 trials. So we've got a number of interesting and I think promising candidates. The Oxford is one, the Moderna mRNA vaccine is another. There's thankfully a long list of these vaccines, but the proof will be in the data that comes out over the next several months.
Thank you. Thank you. Arno? Okay. Thank you very
Dr.
much.
Dr. Murthy, sorry, Vivek. Thank you, Dr. Murthy. Appreciate it.
No,
and we'll move on to the next one. Yeah. All right, go ahead.
Right. Thank you. Next, we have Dr. Julio Frank. Welcome to our summit, Dr. Julio Frank. I understand that you just returned to Miami from last night from out of the country, so we appreciate that you're giving us this time. As probably you'll know, Dr. Frank also was as I mentioned before, the Minister of the Secretary for Health in Mexico. You run a very large university, and of course, the University of Miami, with around 20,000 students in multiple facilities. So what are the considerations that you have taken into account in that university environment? Can you share with us some of those considerations? And also, how does prevention differ from other environments? Can you comment on that, please?
Sure. It's nice to see you both, Gloria and Arno.
Likewise.
The main issue here, as we make these complex decisions, is to try to stay away from dichotomous thinking, binary thinking. You either open or close. Most of the solutions are somewhere in between. And the strategy we're following, I've called it an adaptive, responsive strategy. It's adaptive because we need to recognize that a lot of the drivers of the epidemic in any particular locale, like Miami, in the case of my university, a lot of those drivers are beyond our control. They stem from government policy, and they stem from human behavior in the community that surrounds us. So we need to be adapting constantly, and we need that adaptation to be guided by solid evidence. And it's got to be responsive, because any enterprise, here I'm talking about any enterprise, but particularly a university, we have very diverse community, very diverse people. The community includes people with diverse needs, and our strategy has to be responsive to those different needs. So what we have done is, first of all, take all the data and understand the dynamic of the pandemic as we try to stay away from this dichotomous thinking. First of all, the data we see today in a pandemic reflects events that happened 2 or 3 weeks before. So you're seeing, for example, the number of cases today. And so you need to look at the trends and how things are evolving. And what you see in places like Florida, it's clear that we were at a very good place in the first early phases of the first wave. But clearly, we relaxed some of those constraints, like the stay-at-home orders, prematurely. And that has determined this second spike of cases. However, in some locales, like in Miami-Dade County, government did react quickly and brought back some of the initial restrictions. So, they closed bars again, indoor dining. They made the use of face covering mandatories. I think one of the most regrettable elements of this pandemic has been the politicization of face coverings. This is a public health measure. It has nothing to do with your political view. This is exactly the same reason why we don't allow people who are inebriated to drive a car. It shouldn't be confused with the discussion about individual freedom, because I am, a full supporter of civil liberties. But wearing a face covering is a way to protect not just yourself, but protect everybody else. It only works if everyone complies with that. Therefore, making it mandatory is the same reason why we make many other things mandatory. It's to protect the people, but also to protect the others. So I hope we've gone past that point and we understand that this is a public health intervention. So with all of those elements, we have decided to have a blended strategy. First of all, we have given students and families the option. First of all, every student that has a pre-existing medical condition, we're telling them, do not come. We will deliver a fantastic remote learning experience. You shouldn't be on a campus, because you ask, what are campuses like? Well, they are concentration of people. So they concentrate people. So you, first of all, want to make sure that people with pre-existing conditions, even though our age group has a low risk, those people do have a high risk. They shouldn't come. Same thing with faculty and staff. Secondly, for those who don't have that issue, there's still an issue of anxiety, of fear, and people vary on that. We should be respectful of that. So we're offering that. And probably, and I now have the numbers, about 26% of our undergraduate students have chosen not to come on campus. We have a fantastic instructional option. For those who come, it's not like you're coming to what happened, to what we had before. The model, I call it a hybrid protected model. It is hybrid because even if you're on campus, a lot of the instruction will be virtual, and it is protected because it requires communal agreement and adherence to a series of restrictions. We're making the use of face covering mandatory. Everyone has to have a daily self-report screening. We have a vigorous protocol for testing every student before they show. We'll have a baseline of testing. We'll repeat that. We will have environmental monitoring of the circulation, for example, through residual waters. We have totally, in great detail, redesigned every single space to assure space. And we know we're dealing with young people, so we need a combination also of behavioral interventions. And we're enforcing that with 3 measures. Number 1, what I call persuasion through inspiration. We're trying to inspire students that this is a moment when they need to rise to this occasion and be mindful not just of themselves, but also the health of their family, their loved ones, their friends, their teachers. Second, Positive peer pressure. We've created something called public health ambassadors, other students who will be around the campus assuring compliance. And following the idea of the designated driver to prevent drunk driving, the idea of a public health delegate in every off-campus housing, in every fraternity, someone who will be watching after their classmates. And third, zero tolerance, a very clear message that if you do not comply, you will be asked to leave the campus because you have not proven that you have the maturity to actually live in that community. I am confident that with that combination, we can actually have a safe return to classes, respond to varying needs, and move forward our mission of research and education while protecting the health. It's not one or the other. We should not continue to pit economic activity, or in our case, education and research versus health. The same strategies reinforce both goals, and both are worthy goals. Those are high priorities. They can be pursued in a sort of thoughtful strategy like the one I'm describing.
Wow, that's a very good program
So,
and very holistic. Thank you, Julio. Go ahead, Narnel. Do you want to ask a question, please?
Yeah, thank you, Gloria. Dr. Frank, so even with all those measures, there's probably going to be some transmission of COVID on campus. And as you look at first the microcosm of a university, which you're now president of, but you go back to your previous experience where you were Minister of Health for the country of Mexico, and you apply the two concepts, there is going to probably most likely be some transmission of the virus on campus, even with all those measures. So how would you just articulate the trade-offs there and why you should still move forward, and why you have the confidence, if there are some cases, that you can still minimize or mitigate the spread from those cases? Go ahead.
Yes, we are actually planning to have some transmission. We're expecting that will happen. It's a highly contagious virus. There is asymptomatic transmission. So even with vigorous testing, you might just miss the window when the person was still negative but got infected a minute later, and you missed it. So there are going to be cases. The key here is to keep a vigorous tracing and testing and tracing strategy, and make the provisions which we have now for isolation of cases. We actually have set apart an entire block of rooms. We were very fortunate because we had just finished a whole new residential facility, a beautiful residential facility. So we actually entered the pandemic with more beds than we had a year ago, actually about 1,000 more beds. So we have been able to reduce the density, also with about a quarter of the students deciding to stay fully remote. We have the capacity to create isolation facilities. And one thing that's going to be important, there's a self-reporting here. Students will be told that cheating on that is like cheating on an exam. If you cheat on that, you will be suspended, just like if you cheat on an exam. So this is a truly teaching moment. We are in such need for civic education. This is the opportunity for this generation to receive a live, hands-on civic education. Everyone needs to comply. And our duty in the administration is to make sure that we have all the contingency plans for everything that could go wrong. There could still be a lot of transmission. We have detailed plans of what happens under different scenarios, including worst-case scenarios. We could have a hurricane. We're in Miami. What happens if you have a hurricane alongside a pandemic? We will be facing seasonal influenza. And Adolfo just explained the differences. But one thing we don't know is what happens when the two are coexisting in the same population. So we have developed plans for all of those scenarios, and we will try to be ready for all of them. But it will be a challenge. I don't want anyone to think this is going to be easy. And COVID-19 remains a very serious threat and will continue to be so. So we need to face it head on with a thoughtful and careful preparation.
Are there any distinctions that you see between the university environment, the campus environment, and then just society at large. So what do you see that you're doing at the University of Miami that would translate into society at large that would help mitigate the spread and allow people to move on to, like you're doing, they can still get an education and do the other things in society that people want to do? Go ahead.
It's a great, it's a great question, Arlo, because I like to think of universities as what I call exemplary institutions that can set an example to the larger society of which they are a part. And one of the reasons that has motivated me to move forward with this plan is that if we manage to make this work, it can be an example. And we've seen it in other parts of the planet. We have seen it in countries that have followed the evidence, that have done rigorous testing and tracing, that have enforced the use of face coverings. You can bring this epidemic under control. Now, we're dealing with a very special population of mostly young people. I'm talking of the students coexisting with older people, the faculty and the staff. And those people on the positive side have a lower risk. It's not zero, though. On the negative side, they also are harder to control their behavior, and they have a distorted sense of their own risk. So we're going to have to, we'll tailor this educational opportunity for the characteristics of this group. But I think every time we have a successful, in any country, a successful experience of containing and mitigating the effects of this very complex pandemic, we raise our collective hope that if we work together, we don't give in to the divisiveness, if we do not politicize measures that should be seen as public health, we can actually, while science does its part in delivering better drugs and eventually the vaccine, we can actually bring this under control.
What are the contact tracing practices you're using? And also the second part of the question is, just on the testing. So you're doing pool testing or batch testing? Are you doing it systemically? What's the particular approach?
Yeah, that's an excellent question. We have a whole task force just focusing on testing. We do have an academic system, so we have extensive testing facilities. So we have a baseline. Everyone before they return has to have that baseline. And then we have obviously the symptomatic check. Anyone with symptoms will get tested. If they test positive, we have both human tracers and an application. All of those will get tested, and they will go into isolation. We are planning to conduct we have a random sample for antibody testing, just to understand how is the prevalence of infection, not current active infection, moving. And we will also have in a random sample of asymptomatic diagnostic testing, the PCR testing, both of them on samples. And lastly, we are doing tracking of residual virus. So there's evidence that the virus gets shed through the GI tract. And so if you monitor residual virus, you also get an impression or an idea of how widely it's circulating. If we saw that go up, we don't discard the possibility, for example, of closing down one residential area if we see that there's a hotspot there. So we believe that combination will help. The ideal would be to have a point of care test that's sufficiently specific and sensitive that we could be testing everyone every day. We're not there yet, unfortunately. And so we need to use these other strategies in the face of a less than perfect testing armamentarium at this point.
That is good.
Gloria, you had a question?
Yes, I do have a question, Julio, and that's based on your experience. We have seen that some countries have been very successful in containing the spread, right? And they have contained the spread of COVID. However, when it's time to reopen or the recovery phase, somehow the vast majority are struggling. So they were good in the phase 1, but the phase 2 is not clear what is that path. Based on your experience in the government and also your experience in Harvard and now managing this little city within the University of Miami, do you have any advice or any recommendations for that second phase? And as you see some countries, states very successful in phase 1, but not in phase 2?
Yes, my main recommendation is to avoid that dichotomous thinking. The problem was we started talking about reopening the economy as if it was an alternative, or there was a trade-off between protecting health and reopening the economy. It's obvious that we needed to finish at some time the stay-at-home orders, because that, if it gets prolonged beyond what's necessary, also has a negative health effect. Keeping people at home, isolated. Dr. Murty is an expert on the topic. You don't want to extend that beyond. We needed to reopen the economy. The question was not whether, but when and how to do it. And I think the countries that have been most successful have understood that a premature reopening hurts health and also hurts the economy, which is what we're seeing right now in many parts of the United States. As you open prematurely and then have to back out, you actually hurt the economy. So we need to follow the evidence. And, people think that when you reach the peak, you're now clear. No, you still need to come down from the peak. And if you decide to jump off the peak prematurely, you're going to crash. You need to come down, and then the how, that's the when. The how means you still need to keep physical distancing, mandatory face coverings, hygiene of surfaces and hands, etc. It's not that once you open, everything is back to the way it was before. And that's the main recommendation. Those two objectives are synergistic, not antagonistic.
We completely agree with that. Thank you.
You all enough. Dr. Mullen, do you have a comment you wanted to make?
Yes.
Yeah, go ahead, Dr. Mullen, then we'll wrap up. Go ahead. Dr. Mullen?
What I just wanted to add quickly was that everything that we just heard, when coupled with the kind of communication that we just had, is so key. Because each of us has said so much based on what we know today. Great science, great anticipation, the willingness to say what's not seeming like good science, with the request that the public hangs in there with us as we continue to learn new things. And even when it comes to decisions around health and the economy and what needs to be open a little bit more or closed a little bit more, the confidence that the people communicating that are using those best minds to give those recommendations will help keep everybody on board with us to get us through this. Thank you.
Thank you, Dr. Mullen, and thank all of you. It was an excellent panel and very informative. So can't thank you all enough. For everyone listening in, again, we'll start in about 5 minutes with the final session. But this one was fantastic. Thank you all very much.
Thank you.
Thank you.